Hi everyone. As dentists, we know that the mouth is the mirror to the body. But how often do we consider the health of the body's second largest organ, the liver? The liver performs essential tasks, from metabolizing the drugs we prescribe to synthesizing vital blood clotting factors. Today, we are breaking down everything you need to know about treating patients with liver disease, from spotting oral manifestations to adjusting medications and preventing cross infection. Let's dive in. Now, what happens when liver function is affected? First, we see impaired hemostasis, wherein there is a drop in vitamin K and reduced production of clotting factors. This increases the risk of gingival bleeding. We also see altered pharmacokinetics, wherein the drug breakdown is impaired, which increases the risk of analgesic and anesthetic toxicity, needing a requirement for dose reduction. Also, these patients are immunocompromised, so the risk of cross infection and viral transmission also increases. Let's talk about what you might see in the chair. Chronic liver disease affects multiple physiological systems, and the oral cavity is no exception. When examining a patient, keep an eye out for petechiae or excessive gingival bleeding with minimal trauma. These are the major red flags for poor hemostasis. Other common oral signs include xerostomia, which drastically increases the risk of caries, fungal infections, and traumatic ulcers. Lichen planus, oral candidiasis, which is highly prevalent in hepatitis B and C patients, glossitis, which is frequently seen in patients with alcoholic hepatitis due to nutritional deficiencies. You might also notice fetal hepaticus, that is, a specific breath odor which is indicative of advanced liver disease. Now, if your patient has a history of liver disease, a thorough clinical history is your first line of defense. You need to ask about bleeding tendencies, hepatitis, jaundice, and alcohol use. Here is a crucial rule. For patients in the acute phase of viral hepatitis, you should only provide emergency dental care. Now, for chronic patients, bleeding is your biggest surgical hurdle. Advanced liver disease leads to reduced vitamin K levels and thrombocytopenia. So, before performing any invasive procedures, you must order coagulation studies, including CBC, PT-INR, bleeding time, and liver function tests. Now, if these results are abnormal, delay elective treatment and consult an hepatologist immediately. If surgery is absolutely necessary, minimize trauma and use local hemostatic agents like oxidized and regenerated cellulose, antifibrinolytic agents like tranexamic acid, fresh plasma, platelets, and vitamin K. Also, because liver impairment is linked to weakened immune function, strongly consider prophylactic antibiotics. A platelet level of more than 1 lakh is recommended for surgical procedures presenting a greater risk of bleeding, while a platelet level of 50,000 for procedures presenting a lower risk. A statement by the American Association of Oral and Maxillofacial Surgeons suggests that a platelet count of 40,000 and an INR of 2.5 or lower are considered safe thresholds for tooth extractions in patients with cirrhosis. Now, since the liver metabolizes many of these drugs that we use in dentistry, you generally need to prescribe lower, less frequent dosages over shorter periods of time to prevent toxic accumulation. Now, let's break this down by category. Local anesthetics. Now, amide anesthetics are metabolized in the liver, meaning they can have toxic effects at lower than expected levels. Articaine, is an excellent alternative because it is extensively metabolized in the plasma, reducing the burden on the liver. Also, as long as the combined dose of epinephrine and local anesthetic does not exceed 7 mg per kg, these are typically safe. When we come to analgesics, we need to avoid or be extremely cautious with NSAIDs and aspirin because these have a very high risk of gastrointestinal bleeding and impaired hemostasis. In severe liver disease, paracetamol should be avoided. However, for mild to moderate cases, paracetamol can be a safe substitute at levels up to 4 grams per day for 2 weeks, provided the patient strictly avoids alcohol. Now, most of the antibiotics are safe except for aminoglycosides, which increase the risk of liver damage. Also, we need to be aware that the metabolism of clindamycin is severely slowed down. And as we all have previously mentioned, antibiotic prophylaxis is recommended prior to bleeding interventions due to compromised immune function and high risk of bacterial endocarditis. Now, finally, we also need to protect ourselves and our staff. Hepatitis C can survive at room temperature on clinical surfaces for more than 5 days. So, universal protective measures and strict sterilization protocols are mandatory. If you or your assistant accidentally suffer a needle stick injury, do not panic. Instead, wash the area carefully for a few minutes with soap and water. Do not rub because rubbing can push the virus deeper into the tissues. Apply pressure below the level of the cut to induce bleeding and wash out infectious debris. If a mucosal surface is exposed, repeatedly rinse it with sterile saline or water to dilute the viral load. Immediately confirm the patient's hepatitis antigen status and seek post exposure prophylaxis if necessary. Treating